Right, we'll kick off in about 2 minutes. Thank you for everyone who's joining us thus far. All right, it's 11 o'clock. Good morning and welcome to this month's bi-monthly science webinar for Health Data Research UK. For those of you who are new to these webinars, they take place at 11 a.m. on the second Tuesday of every other month, but we're taking a bit of a summer break. So the next date for your calendars is actually Tuesday, the 13th of September. These webinars include a diverse mixture of research talks as well as fireside chats aimed at members of HDR UK's community across our sites, hubs, alliance, fellows, PhD students, public and patient groups, and more. The webinar is also open to the wider health data science community and the public. And given that the purpose of these webinars is really to help us build that one institute ethos despite our distributed setup, we really want this to be as two-way and interactive as Zoom can possibly be. So if at any point you have a question for our speakers, please do use the Q&A function. Right, so my name is Holly Dawn. I'm the research manager here at HDR UK, and I'll be your host for today's webinar, marking Mental Health Awareness Week. Over the next hour or so, we'll discuss the progress that is being made in harnessing data science to improve care in mental health, and importantly, really how this progress is being guided by close involvement of people with lived experiences, making sure that those people are able to influence not just the security of technologies being developed, but also the research questions that are being asked and answered. Today, first up, we're joined by Richard Dotson from KCL and UCL, speaking on insights derived from real world data, including electronic health data, as well as data generated from mobile devices. And he's going to discuss how these approaches are helping his group map the trajectory of patients with serious mental illnesses and multimorbidities to ultimately improve care and inform future research. Following Richard's talk, we're joined by a team from the Network Data Labs, and the team includes Matthew, who's Associate Director for Transformation at Imperial College Health Partners, Claire, who's the Patient and Public Involvement Engagement Lead at the Institute of Global Health Innovation, Roberto, who's an Analytics Fellow at the Institute of Global Health Innovation, and lastly, Evgeny, who's a Data Scientist at Imperial College Health Partners. And these four are going to join me in a fireside chat on their latest report, which is exploring how children and young people as access to mental health services and the severity of their mental health difficulties has been impacted by the pandemic. And last, certainly not least, we'll be joined by James Pickett from the HDR UK Central team, and he's going to give us a whistle-stop tour of his work, including the Mind Hub for mental health, as well as what's up and coming at HDR UK. So without further ado, I'd like to hand over to Richard Dotson.
Thank you, Holly. Hi, okay. Let me just share my screen. Can you see my first slide, can you?
All good, Richard.
Okay, thank you. So, yep, thanks for that intro. I'm going to talk about some of the work on electronic health records and mobile devices. I'm based at King's at the Institute of Psychiatry, Psychology and Neuroscience within the Department of Health Informatics, and also at UCL at the Institute of Health Informatics there. So I'm going to begin with a focus on South London and the Maudsley NHS Foundation Trust, which provides the most extensive portfolio of mental health services in the UK. And this is where the Maudsley NIHR Biomedical Research Centre is based. So it has a base population of about 1.4 million, with electronic health records since 2007, totaling about 500,000 patients. And it's got a wide range of clinical services there. And so in partnership with the Institute of Psychiatry, Psychology and Neuroscience, it's one of the world's leading centers of mental health research. And so we all know, I think we all know the value of electronic health records. There's huge insights to be gained from having access to electronic health record data due to the volume of unutilized data that's contained within. This is a vast volume of data, much beyond what we have available to us on how medications work, beyond trials, for example. But a large proportion of the information within the electronic health records is both siloed in lots of old legacy disconnected systems, and it's also a large proportion of it is in text, particularly about 80%, we think, particularly within mental health care, where there's a real preference for recording information in narrative. And so just here I show at the South London Maudsley the evolution of text versus, or the volume of text versus structured information that's been collected over time since the initiation of the electronic health record in about 2007. So you can see that on the top trace there, the top plot, there was an increase in the amount of information collected within structured fields up to about 2010. And then the electronic health record became so kind of bloated and complex that people really stopped putting things into structured fields. And you can see that on the bottom trace, there's been this gradual increase in the amount of information being dumped into unstructured or free text fields. And so that means that we have to, in order to be able to utilize these electronic health records, we have to be able to consider the amount of the information within text as well as structured fields. And so just on the right there, that's an example of mini mental state examination scores, which are, a standard measure, and which should be recorded in structured fields, but only about 10% of those actually are being. So very early on, in about 2007 or 8, with NIHR funding, the Clinical Record Interactive Search Platform was initiated, or CRIS as we call this. So it's basically a research platform comprising a security model of service user-led governance, a data processing pipeline within a TRE, and a service model based at the Biomedical Research Center. And so this includes de-identified electronic health record data, which is updated every 24 hours for the purpose of research. And this model of governance and technology has been exported to a range of other UK mental health trusts and has produced a lot of many high impact outputs with close to 200 publications, I think, over time. Its core functionality includes a clinical data linkage service with internal and external linkages, contextual information on local environment, for example, mortality, cancer registration, hospitalization, etc., links to the National Pupil Database, London Ambulance Service, neonatology services, for example. So a wide-ranging set of linkages established through the Clinical Data Linkage Service. And we've also developed, further developed a generalized solution to the issue to address the massive bottleneck around unstructured data, and that's something we call CogStack. So this is a natural language processing suite of tools, which includes the ability to assign standardized vocabulary codes such as SNOMED to clinical text. So this covers off things like symptoms and multimorbidities. And this clinical coded data has further use cases, including quality improvement, clinical research, and developing decision support systems. And so we've disseminated this widely, both through the HDR Text Analytics Program and funding from funders such as NHSX to both mental and physical healthcare settings. And key partners within that have been King's College Hospital and GCLH Hospital. And as part of the NLP, the natural language processing capability, we've developed models or modules, AI-based modules that have been pre-trained on a huge corpus of real-world NHS clinical text data. This includes all the electronic health record data at King's College Hospital, and then we're performance testing this across a range of other hospitals, both mental and training at both mental and physical healthcare at secondary healthcare settings, so that it understands the breadth and depth of clinical text, and so that we can link, start to link physical and mental healthcare analyses. And so we're just at the stage now of being able to share these models that have been trained. If people are interested in this, then interested in collaborating, get in touch. We're looking for Fastfollower sites that are interested in adopting some of the NLP. So I just want to show an example of where we are, of what this actually means in reality. So just in terms of the generating annotations from text, such as SNOMED annotations here, this is just a demo site, which the link is in the previous slide. But this just allows you to paste in some text and it will generate SNOMED type annotations from this. So here we can see that, we have a disorder, this one here, toxic epidermal necrolysis. This has been annotated as Lyell syndrome with a SNOMED ID, a confidence score, and the status, context status for that disorder. And so, that's just how we go about. That's an example of the model that generates structured SNOMED concepts from underlying free text. I just want to show you something else as well. So we've built models that are able to take that text and those annotations generated from those texts, and we've applied a GPT-2 generative language modeling approach to those annotations to generate essentially timelines for individual. And what you can do with this is you can feed the model a prompt. So in this case, we're feeding a set of symptoms or a set of kind of entities, SNOMED entities that have been extracted from the record, created this timeline for this individual, and then we can make a prediction based on what it's learned on over 800,000 patients at King's. This is work done with James Teo at King's. We can predict, say, disorders, and looking at this, you might predict that the patient, the next SNOMED concept that this patient will have could be Parkinson's disease, and indeed that comes up there. So we think that this modeling approach at the moment is performing at the level of an undergraduate medical student. But if we want to look at, say, medications and substances in terms of predicting what somebody with these set of characteristics would have, we can see that we're getting Parkinson's disease symptoms, medications coming through as a kind of recommendation almost, with a probability for that particular patient. And so this has been trained on everything over 20 years for 800,000 patients. And you can essentially look at or predict disorders, medications, procedures, symptoms, and findings. So this is not a medical tool by any stretch. It's something that we can use to learn and understand practice within our hospitals. And so to just go back to where I was, so there's a link there if you want to test out the annotation tool, and I could share that in the chat afterwards. So I just want to move on now to talking a little bit about some of the applications of this. So SLAM, this kind of work. So SLAM serves a population with a high prevalence of mental ill health, and particularly psychosis. And people with psychosis have severe and prolonged, basically severe people with psychosis or severe and prolonged mental illness, which usually includes psychosis, are at risk of dying on average 15 to 20 years earlier than other people. And 2/3 of these premature deaths are from avoidable physical illnesses, including heart disease and cancer. And so this is one of the greatest health inequalities in England. And costs, just in psychosis alone, the costs are estimated to be 11.8 billion per year. So to effectively prevent, intervene with these physical comorbidities and improve health for this population, a key prerequisite is to understand how and when these diseases occur during the course of SMI. So we have a first study here from Rebecca Benden and Jelko, who designed and developed and validated a strategy to extract physical health conditions from clinical notes, which will come in mental health services, and then examine the prevalence of these conditions within individuals with serious mental illness and explore the prevalence in different ethnic minorities and socioeconomic groups. So they extracted 21 of the most prevalent conditions from 15 million documents across from 17,500 patients. They found that 10 most prevalent conditions, including diabetes and hypertension and asthma, and the most prevalent combination in this population include diabetes, hypertension, and asthma. And then they looked at, so they found that around 40% of our cohort had multimorbidity, from which about 20% had complex multimorbidity. Age, sex, and ethnicity and social deprivation are found to be key to understand the heterogeneity and differential contribution to disability levels in the population. And just as an example here, COPD has high prevalence in those from an Irish background compared to other minorities. Diabetes more prevalent in South Asian with bipolar disorders than other minorities, or South Asian with schizophrenia. So we then moved on to further link this data to HES, creating a data set of around 8,000 to 7,000 episodes for 8,000 patients, and applied a bipartite network modeling approach, whereby nodes are divided into two sets of patients and diseases. And this allowed us to generate a deeper understanding of the relationships between patient attributes and diseases. And we're able to model the temporal evolution of patient diagnosis networks. So that's all well and great, and we publish findings from that and go to develop a greater understanding. But critical is the next step, I think, was to really translate our findings. So we need to need an approach through which we can apply these findings back to the bedside, and this has been enabled through our Centre for Translational Informatics. And I just want to show here an example of that. We developed something called Viewer as a platform enabling population health management for psychosis services. And this one highly commended for Best Mental Health Partnership with the NHS at this year's HSG Awards. And this approach is really a kind of clinician-orientated collaboration between the psychosis CAG, a clinical academic group, service users, informaticians, and computer scientists to optimize the use of the EHR and to translate the patient-centered research to clinical practice for better care and using informatics approaches. So it involved collaborative working to develop information models that met the clinicians' needs. It includes things like the natural language processing to extract the insights from the data at scale, and then an innovative and kind of thoughtful approach to interactive visualization to identify patients with unmet needs from multiple perspectives. And then we had support with rollout and responding to feedback to engage staff and refine the platform. And so this was really about how we implement these things, and there was a lot of lessons learned around implementation. Directly within services. And so View is used by more than 180 clinicians within SLAM to improve patient care in various ways, ranging from care delivery and planning by frontline clinicians and resource relocation by the management team. And so just in the top left, we have visualizations that are facilitating comprehensive review of antipsychotic medications. So this is vital for prescribing safety and also useful to identify patients with treatment resistance, which is actually one of the most disabling forms of psychotic disorders. On the right top, we have a wide range of clinical measures on physical health statuses, allowing clinicians to monitor and recognize adverse drug and treatment effects, and then inform decisions on care planning. Bottom left is a visualization of demographic and geographic features against the clinical outcomes, such as bed and medication use, helping us identify care inequality and allowing the trust to make a better resource planning for relocation. On the bottom right, we have, we're just showing here how we integrate with the electronic health record. So we're zooming in from the population level down to individual level and then click through to the patient record from there. And so this has had a substantial improvement on the assessment of physical health within the trust. So it's used by physical health check team with only 6 members to efficiently manage the whole kind of active caseload of the trust, which is over 33,000 patients. So substantial improvements there in each category of physical health checks over a short time period. So I just want to switch here in the last couple of minutes to just talk about the opportunity when we're thinking about data that's collected from outside of the electronic health record system, and data that is patient generated. So on the top row here, we can see that patient data collected through routine healthcare is very kind of sparse and sporadic. We only collect it during periods of diagnosed or post-diagnosed disease or at diagnosis, and sporadically during managed disease, where the bottom row here really shows that we have the opportunity here to collect data continuously and passively and evasively through healthy at risk all the way through to managed disease. And so we have the ability to kind of assess and monitor a range of kind of behavioral, physiological and environmental measures. And what we want to do is we want to determine the temporal architecture of the disorders and the symptom changes. And using these measures, we want to identify thresholds for changing these digital biomarkers that represent thresholds for relapse. Particularly here, I'm talking about a project around major depression, and which is part of a RADAR CNS major program, European program. So we developed a platform, a generalized, scalable and extensible mobile health platform to be able to enable us to collect passive data and active data, passive data being data from sensors, active data being clinical assessments, questionnaires, ESN type data where the individual is consciously entering that information. That platform we partnered widely on this platform with technology partners, and we have a range of, I guess what we're trying to do here is generate digital phenotypes, and digital phenotypes that are transdiagnostic, that are reusable phenotypes, and we're packaging these up for reuse across a range of disorders. And this is an example here of the kind of features that we're generating from these data sets. We're generating measures around mobility. This is just in depression alone. As part of the RADAR CNS program, we've been testing for associations and finding associations with mobility, particularly measures of home stay derived from GPS data, measures of sociability derived from Bluetooth connectivity, combining that for a more specific signal with GPS. We're looking at gait and sleep signals and measures and quantifying those and testing for association with major depression symptoms. We've been checking, recording, annotating, measuring speech. So prosody is the melody of speech, and the change in rhythm, stress intonation, and the affects the meaning of a sentence and overlaps with emotions. And so we have a range, 24 different speech parameters that we collect across this audio data, which includes speech timing, prosodic features, phonation, and articulation features. We've got the largest number of participants for the longest data collection period globally in major depression. So a critical factor is to understand engagement, how people engage with these studies, and that's something we've been studied, and actually crucial to that is the fact that we co-design all of our studies with participants. So the platform is being used very widely across a range of disorders, physical and mental health. Of those that we know about, because it's all an open source platform, there are more than 45 different case studies around 20 different disease areas, 50,000 participants in studies. We have citizen science studies, cohort studies, where the patients have been, or participants have specifically been recruited. And then we have a range of devices and apps that people can test and pick off the shelf in order to apply those. And so we're really kind of transforming the ecosystem towards something which is integrated, which combines mobile health data with routinely collected data. And a particular next step for us is to try to link mHealth data to routinely collected data through NHS-RD linkage. And just to finish off, I just want to mention the data mined HDR Hub that we're part of, which aims to kind of work more nationally and collaboratively to disseminate and scale up and to identify, to undertake and address a number of challenges which are described here down on the bottom slide there, bottom of the slide. And so just to thank all of our thank key funders, key collaborators, and our patients, participants, and carers in working with us on this work, this program of work. Okay, thank you.
Thank you, Richard. It's a grand scope of work there. It's absolutely fascinating and, dare I say, world-leading. A few questions in the chat, so we'll cut the question period just by a bit to make sure we stay on time. First from Matthew, he's asking, do your NLP-derived SNOMED codes get input back into the record?
Yeah, that's a good question. We're working on, we have done that in a couple of examples, and we are working on that with a couple of the sites. At the moment, we're working out what the best way to do that is. At the moment, we do make it available in a kind of structured type, kind of SQL database, and also within graph databases such as Neo4j. How we actually get those annotations back into the record is still a kind of piece of work that's ongoing, but we have done a couple of test cases on that, but there's still quite a few things to work out.
Brilliant. And then Matthew followed on, have you done any comparisons between relative predictive capabilities of algorithms built on structured data versus unstructured data versus structured and unstructured together?
We have, yeah, we have actually. Not a little bit in mental health, but actually quite a bit outside of mental health. So we've done it with some intensive care data, for example. And we found that there was value, there was definite value in incorporating the free text data. I mean, you lose, obviously, there's about a trade-off between, accuracy, I guess, from information derived versus from text. We also did a lot of work in COVID, actually, in extracting information from text for that, and evaluating things like the news score. And we found text to be really quite valuable. But yeah, so we've done some work in intensive care and found that text did add value.
Thank you, Richard. And just one last question from the chat, and I think this goes back to sort of what you're presenting in your earlier slides on that sort of 20-year gathering of the health data on mental health. And just in terms of age brackets, was that adults only, or did that also include adolescents?
Yeah, no, it included adolescents as well. So there were a range of, we got a large range of services within SLAM.
Okay.
Which includes child and so it includes CAMS, if you see that.
Ah, yes, brilliant. Yep. Thank you, Richard. Yep. All right, great. So if anyone has any remaining questions for Richard, if you're willing to stick around for a few minutes and answer any questions in the chat, that would be great. One from James that perhaps you could provide a link or whatnot in the chat is how can people become a fast follower? What's involved in that? So if you wouldn't mind addressing that in the chat, would be great.
Yeah, so that involves getting in touch with us. We have the platforms are open source, so it'd be a case of you don't require a huge amount of hardware. It'd be a case of downloading and setting up the platform, getting access to your own data, and then we would be able to support a little bit in that. But then it'd be a case of signing the model sharing agreement, and which provides 2 years access to the models as they've been trained, and then testing those and further tuning those to your own setting.
Great.
But there's a lot, there's a lot of documentation and quite a growing kind of online community around supporting each other around the various deployments. So the link that I shared for the model where I tested that's just been trained and on public data. So that's just been trained on the mimic data. That's why I can show it there. So it's not, that's not performant in any way. It works quite well, but I mean, the models that have been trained on real NHS data across multiple hospitals is getting pretty good.
Great, thank you. Well, hopefully we found you some fast followers today. Thank you, Richard. If you can stop your screen share. please. And next up, we are going to talk to the Network Data Lab about their recent report looking at mental health in adolescents and how that's been affected by the pandemic. So I'll hand over to Matthew and Evgeny and team now to present for 5 minutes before we head into a fireside chat. Thank you.
Thank you very much, Holly. Good morning, everyone. It's a pleasure to be here today. So I'm Matthew, and we've got a number of us from the North West London Network Data Lab team who are going to talk you through our approach to looking at the impact of the pandemic on children and young people's mental health. I think just before we explain kind of what the Network Data Lab is, I think we just wanted to focus on our approach. And what's been really important to us is that we're citizen-led. So we've made sure that we've had young people's voices really help shape the questions that we work on. Two, and what's been brilliant around it is trying to share learning across the UK, and we've got lots of different labs across all of the countries in the UK. And then the third is around how we kind of use this linked data to drive local impact and making sure that we're getting the benefits for linked data. So next slide, please, Evgeny. And if you head on to slide 3. So the Network Data Lab is a 2-year funded health foundation program. So we are one of 5 different labs across the UK. So we cover North West London, which is a population of 2.3 million or so, and there are 3 different organisations in North West London that help contribute to this. So here's Imperial College Health Partners, which I work for. We've got North West London CCG, but then we also have Imperial College London's Institute for Global Health Innovation, IHI. And it's been really important that we have a multidisciplinary team that works together, which allows us to kind of learn and link from our communities to help shape the questions that we follow. Next slide, please. So over the course of the 2 years, we are looking at 3 different topics. So our first topic was looking at those who are clinically extremely vulnerable and who are shielding during the first few months of the pandemic. And the second topic is around children and young people's mental health, which we're going to be talking through today. And then the third one is around social care, where we're looking at research questions with regards to unpaid carers and also looked after children. But the focus of today is very much going to be children's and young people's mental health. And I'm going to hand over to Claire, who's going to talk about our approach to engagement to help shape this topic.
Yeah, brilliant. Thank you, Matthew. And thanks, Evgeny. I think we've got, yeah, there we go. So PPIE. So hi, everyone. Thanks for having us. As Matthew says, PPIE to me is the why. So we wanted to really engage with the young people in Northwest London who the whole project is all about. So why and how this was to help us with prioritization, to make sure that our data and the way we're looking at it is focused on things and topics that matter to the young people in that area, as well as understand trends that arise and the analysis, as well as the communication, so the messaging, how things are framed, and make sure that this also is accessible to the public, but also engaging to read and learn about. Then also implementation, by engaging young people, we can also identify opportunities based on their lived experience to take forward for policy or practice, implementations, or where we might need to do more work and look into more research and where that's needed. And then last but not least, the transparency of sharing our work and giving people a meaningful voice in how we shape it. And then in turn, we hope to build trust. We had a young people's advisory group, you can see on the right-hand side here. And, I'm really pleased to say that there was up to 20 young people from 10 boroughs in Northwest London. 63% had lived experience of mental health. 65% were from an ethnic minority background. And as well as that, 20% identified as non-binary. So we're always in PPIE trying to reach those that are often seldom heard in research. And I'm really proud to say that we worked hard with our local partners to find these young people. We also had a professional reference group, which is where we could bring their direct quotes from the Young People's Advisory Group to professionals and decision makers, as well as present our data as well. And then we had an online prioritization survey. This is where we opened it up to the age group of 11 plus, whereas in our Young People's Advisory Group, we did 16 to 20-year-olds. So yeah, really proud of the PPIE. Thanks, Evgeny.
Great. So, hi all. My name is Roberto. I'm gonna briefly talk to you about some of the analysis we did for this piece of work. So, just bear with me 1 second. This slide, this is a bit busy, but essentially, one of the sort of outcome measures we had for this analysis was the number of mental health events. And by mental health events in this analysis, we mean any sort of essentially the total count of patients that had a SNOMED code with that sort of referred to mental health, a GP prescription of mental health drugs, GP referrals to mental health services, acute admissions for mental health reasons, or A&E or outpatient visits for mental health reasons, as well as sort of mental health appointments to one of the trusts in Northwest London. So any of these sort of categories that we have, we combine into the total number of mental health events, and this is sort of what we'll be looking at in our analysis. So in this graph, what you can see is the count of these mental health events over time, and for an analysis, we are looking at data from February 2015 to October 2021. And in this graph, you have essentially the total number of mental health events. In the top left graph is the total, just without any sort of demographic breakdowns included. And then by age bracket, by gender, by ethnicity, IMD quintile, CCG, and care setting. The last two graphs just split apart, just so that they look a bit better in terms of the y-axis. So one of the analysis goals that we had is we wanted to essentially try to quantify if in this trend that we're seeing that is sort of going sort of up the number of mental health events over time. We wanted to see if COVID had a significant impact in the number of mental health events. So next slide, please. What we did for this analysis is we conducted an analysis that is interrupted time series analysis, in which we essentially try to quantify the impact of an event. And by event, in this case, is the start of the COVID-19 pandemic. And we consider that it started for the purposes of the analysis, it started as of March 2020. So what we try to see is with the data we have, we look at the data, the number of mental health events that we're seeing in this case. In this graph, you can see that is the little gray dots. The trend in the pre-pandemic values that we had, which you can see is the blue line, and then we see the values that we actually saw, which in this graph is the yellow line. And we sort of tried to model the values that we expected that we would have seen had COVID not happened, had the pandemic not happened, which is in this graph is the red dashed line. And with this model, what we quantify is that, for example, in this case for males, we identify a significant decrease in the number of mental health events that we saw compared to what would have been expected. And this was a decrease of 12.5%. So we conducted this analysis for all the sort of the demographic variables that we had. And just to not show you a lot of the same type of graph, we sort of summarized it in. We can go to the next slide, please. Yeah, so we look at this by age groups, by gender, by CCGs, by sort of care setting, quintiles, and ethnicities, as we saw on the first slide. And what we saw is that for people age 5 to 11 and age 18 to 21, they had significant decreases of 17.4 and 25.2% respectively, while all the other age groups had slight decreases, but these were not statistically significant. In terms of males, as we just saw, there was a decrease of 12.5 in the number of mental health events that we see post-pandemic. In terms of CCGs, there were 3. These were Hammersmith and Fulham, Ealing, and Hounslow that had significant decreases as well. In terms of sort of care settings, sources of mental health events, we saw that the number of GP prescriptions on mental health drugs had decreased compared to what would have been expected, as well as the number of mental health related outpatient events. In terms of IMDs, we identify those that lived in IMD quintiles 2 and 5. And bear in mind, 1 is most deprived, 5 is least deprived. Had also saw significant decreases. And then in terms of ethnicity, while we saw some changes, none of these were significant. so we couldn't make any additional, but we couldn't draw any conclusions from there. And that's a sort of a brief summary of some of the analysis that we have in our report, which includes some more. And I think that's the end of our presentation. If you go to the next slide. And yeah, thank you all for listening. And this is the if you have any additional comments or questions, just feel free to reach out to us.
Great, thank you to the team. That's a wonderful presentation. So to kick off the fireside chat, I think from this panel today, it's really clear that the Network Data Lab brings together, people working across disciplines, across areas of interest. So I'm wondering if you could tell us a bit more about what this looks like in practice.
So I think it's been really important, and as Richard's presentations outlined, we all work across lots of different teams and so on and so forth. So being able to set up the structure for those teams to be effective is critical to kind of make some of this work happen. Our lab itself is a 3 organizations, but we also work within a system. So we have all the other labs across the country, but then we also have our local ICS. I think internally, it's important that we make sure that everyone is empowered to lead within their specialism, and are given them the decision-making authority about where we make decisions. But then it's also, and it's been a key part of my role, given that I sit in the transformation team, is making sure that we kind of link in with our specific partners. So we've, as Claire said, we've made sure we have professional reference groups, which are part of the NHS kind of ecosystem, and that helps us really kind of translate these results into potential service change.
Brilliant, thank you, Matthew. And sort of diving a bit deeper into the analytics or the data set itself, what are the biggest opportunities and challenges when working with the Discover data set?
Yeah, I can speak to that. So I think one of the biggest sort of opportunities is just because it's an integrated data set, so it has like lots of different bits of data that sometimes would have been sort of seen separate. So here, because you have data from GP, acute care, community care, mental health data, as well as social care, from a research point of view, is quite interesting because you can see sort of the continuum of care and study it as a continuum instead of just look at it as individual buckets. So I think that's by far sort of the greatest advantage it has. In terms of challenges, there's sometimes we found issues, for example, in this analysis, that some variables are not always like completely well populated. So for example, in our analysis, we identified that ethnicity was missing for quite a few of the patients, and so there's things that that can still be improved. There's also a question of sometimes we also identify that like trying to look at like the ways the data is structured. Sometimes looking at previous versions of the data is complicated, whereas you can just look at how things are in like most current snapshot. So I think those are sort of the two most the two biggest points that we identified with this analysis.
Thank you, Roberto. And you mentioned sort of ethnicity and ethnicity coding, and I wonder if the team could talk a bit more about work that's needed to improve data collection so that analyses, reflect diverse populations.
Yeah, so I think we're lucky to have Discover, which is a linked data set. So what you can do is try and pull down ethnicity coding perhaps from different sectors, so perhaps the GP records, which can increase your chances of finding ethnicity data versus perhaps only looking at secondary care systems, but it's still not perfect. So I think it's both our kind of moral and a legal duty for the Equality Act 2010 that we are able to analyse disparities, but that means actually a strong initiative about coding at source. So we've been doing some work at ICHP looking at LGBTQ+ coding because we have to look at all protected characteristics, but I think it's important that we actually need to work with communities to understand how they want that data collected. I think in the vaccination program, we made a few missteps in how we looked at ethnicity. So it's really important that we engage with communities to understand what's an appropriate contextual way to code this data in. But it is something that all ICS is actually mandated to do as part of the operating guidance for this year.
Thank you, Matthew. I couldn't agree more about engaging the communities. It's a really important first and critical step of that work. Claire, so really great to see the PPIE embedding element in this project, and something that is quite important at HDR UK, and I'm sure our community is very interested in. So could you just tell us a bit more about your experience embedding that lived experience or public voice into the work?
Yeah, absolutely, Holly. And I think it's a really important topic, because what we're talking about here is lived experience, but also the system. So I think whenever we were going into this with engaging with young people, you know, mental health implications of even discussing this data needed to be on everyone's radar, because what we were potentially going to show them was, you know, increased demand on the system because of increased incidence due to the pandemic, which can provoke for some people further anxiety, that they're now further down the waiting list, that there's more demand, that 1 year would be is now 2 years. So we had to be really careful and sensitive about how we approach this. So ways in which we consider that, and that's like safeguarding as well, so that people felt supported, but also that they had somewhere to go afterwards. So if they were digesting this and there was a follow-up thought, there was somewhere to go. So for us, it was having that going into this, being really clear about mental health service supports that we could signpost to, but also having, you know, in our YPAG group, having mental health first aiders on the call, and having that, you know, time where they could nip out on Zoom to a different breakout room and just take a minute, because it can be difficult to hear that the system is continuously overloaded. I think as well as that, what's really important and what works quite well is giving people advance notice about what's going to be covered. That can also prepare them for what they're going to see or what they potentially might be asked. And in terms of feeling like that psychological safety, it's not compulsory to have your camera on. As a young person, if you're sharing a bedroom with your sister in Northwest London and you want to have your camera off, that's okay with us. So having those real key messages in advance also builds trust. You know, we're here to work at your comfort levels, because that's what's most important and paramount in that well-being. I think as well as that, you know, having different facilitators and amongst us as a group to try and overcome those power dynamics, right? That can feel, you know, we're the research team and we want to talk about your cohort. We, you know, keep it friendly, keep it light, but also kind of share that amongst the colleagues in terms of facilitation as well. So it's not just always one person at a time, because it builds trust with other people on the call, as I'm sure we can all relate to. And also in terms of accessibility and inequalities, having offers like we could send out Wi-Fi dongles if they were going to use, you know, they didn't have access to Wi-Fi or internet at home. Those considerations as well were really, really important to be as inclusive as possible. So overall, it's been a learning experience, and I'd say rapport is the most. So that constant feedback as well. How did you find that? What could we have done better? We want to learn and we want to improve. So having that open dialogue is also paramount.
Thank you, Claire. I'm sure our community can learn a lot from you in that experience. That was great. I guess we should open it up to the floor for questions as well. So there's a question in the chat from Justine. So saying the reduction in rates of expected mental health events seen in some young people, is this a real reduction or instead underreporting due to people being unable to access care? And as you mentioned, because there is pressure due to the pandemic.
So I think I'll take this one first. So I think it's important to remember the bounds of what we can see. So we are only focused on what is coded and what has been an actual event. So, and I think there's an element of your question which strikes to the unmet need. So we anticipate that, agree with you that we would have expected to see massive increases because of all the lifestyle shocks which have been associated and directly reported to our ppie and engagement. But because of the actual access challenges on the supply side, we're not seeing that through. So therefore, I suppose one of the key kind of arguments and findings is we know that there are young people that need more mental health support, and we see that through expansion in CAMHS waiting lists and so on and so forth. But we would go further that actually there's probably an unmet need on top of that, where people aren't actually accessing these services in part due to perceptions and so on and so forth. And that's where for the specific groups that Roberta outlined, there may be specific access challenges which the healthcare system has to be more proactive about, because even versus where we would have expected to be, they're lower than we would have anticipated.
Thank you, Matthew. And last question that we have from the audience, unless anyone wants to post any more using the Q&A function, is from James asking, did you look at emergency department events?
Sorry. Yeah, so I mean, we didn't look at it separately in our sort of total measure of mental health events. It is included in there, but we sort of took the sort of general overview approach of including all the sort of the mental health categories that we include in the analysis sort of together.
Thank you, Roberto. And last question, would be great to hear from you, Evgeny, on what are the plans? What are the next steps?
So we're gonna present, first of all, we're gonna put our report on GitHub, and Matthew is going to present the results as HSR UK conference in July. And we're gonna put it as well on our CHP website. And policy-wise, it should be shared with also some NHS bodies like NHS Confed or NHS providers. And the next topic, as Matthew mentioned, is social care. So we're going to study unpaid carers and looked after children, health issues, particularly the effect of COVID. We're going to do descriptive stats. We're going to study what are the prevalences of particular health conditions among these groups, and are there any troubles with healthcare access. And yeah, we're having workshops with Health Foundation and discussing potential challenges we could face with these tasks.
Brilliant. Thank you to the team from Network Data Labs. Really fascinating piece of work. And I hope that our community can become involved in the workshops and whatnot as you develop this in any way. So I'd encourage them to reach out to you directly. And with that, we're going to close up the fireside chat and invite James from HDR UK Central just to give you the last sort of 5 to 10 minutes whirlwind, what's going on in HDR UK and what does James' day-to-day look like. Over to you, James.
Thanks so much, Holly, and good afternoon, everybody. Yeah, I'm just here to sort of put this in the bigger context of all the activities at HDR UK. My title at HDR UK is Hub Development Manager, and my role is really about looking at how we can develop further additional data sharing initiatives above and beyond sort of our core business, as it were. So I'll just run you through a couple of slides about what's going on in the Institute at the moment. So first and foremost in our mind is that we're going through our quinquennial review at the moment. This just shows a timeline of where we've grown since 2017, but we were funded in 5-year cycles from UKRI and the devolved nations and our core funders. And it's come up to that time for them to look at the progress that we've made and for us to set out a really compelling vision for the next 5 years about how we will build on all the COVID learning that we have and where we want to go in the future. So we're really in the midst of this at the moment. And next week and the following week, there are 2 3-day-long interview panels where a panel of the funders and their representatives will really stress test the kind of proposal that we've sent into them back in February. Since then, it was actually reviewed by over 60 peer reviewers, different elements, and the feedback has been very positive in the UKRI scoring systems. Over 80% scoring as sort of a 5 out of 6 or 6 out of 6 in the areas that we're looking. So we have a very strong bid, but they will test that. We will then receive some feedback and some iterations on areas and work into the autumn to sort of draw up a new contract. Hopefully, assuming everything goes well, to fund HDR UK beyond March 2022. So lots of positive signs, but massive work going on with the team in HDR UK on that at the moment. And just very briefly, you've probably seen this slide elsewhere, but this is our very top line strategy of what was in that. We will continue to build the infrastructure and services that unite the UK's health data, things like the gateway, things like the alliance, things like our work with the public and on innovative governance models. That will be supported by 6 driver programs that will really be used to advance science in areas that we think are really key, but also to really test and use and feed back to that infrastructure that services that we're making. So it's not being developed in a vacuum. And really underpinning this will be sort of the convening and enabling role that HDR UK plays in developing its partnerships. So that's our QQ. Something else that's happened in the last week, and this is to give credit to our host, Holly Dawn, who's really driven this, but to all of you as well who may have contributed this. So our research fish return was received. Over 2,500 papers affiliated with the Institute over to date between April and March this year. 66,000 citations, which Holly Dawn has cleverly worked out is 6 times more than 2,500 papers that aren't affiliated with HDR UK in the same areas. So we think that sort of the work that HDR UK is supporting is having high impact. All the papers on a GitHub link there, we can pop it in the chat, and people are free to explore sort of the collective outputs that everyone here is contributing to. But just to say thank you very much. You can see how we're going for a QQ, and actually having this data at our fingertips is extremely useful to any BDI reviewers next week. So just talk a little bit more about my area and where we're at. We heard Richard mention the hubs earlier, but just to let you know, we've heard about Discover Now and actually the Discover data set as well. So we've heard from the 2 presentations about several of the work hubs, but we actually have 9 hubs currently that are up and running and active, taking a national role in creating data, improving its quality and access, and wrapping a services around that, including embedding the public and patients and everything that they do to bring users to that data. And so we have 9 hubs currently working in these 9 areas. A number of them have just undergone a large review, their milestone 3 review, which is sort of conducted when they're 2.5 years through. And we're working that through at the moment, but it's really terrific to see how many of them have become almost sustainable, but in which I mean found enough business to keep them going and to develop and push forward in that short period of time. And again, from that milestone 2, just pulling out some of the key messages that actually those hubs have delivered over 500 projects between them, made 180 data sets available, and can actually get data to people in a median time of about 4 weeks from putting in applications. So they're really working very well and delivering scale, impact, and being patient-centric in their work. Datamine, we heard about that, and we heard that from Richard. So Datamine is one of our newer hubs. It's set up 6 months ago. You can find it on the Innovation Gateway, and you can find the data sets that it's creating. It's sort of 6 months through, it's setting up its ways of working in its business. It has wants to work with industry, but needs to do this in a way that represents the sensitivity that sits around mental health data. So very much building its public and patient work first, and industry forum. There's a resource called the Catalogue of Mental Health Measures that you can find, which documents all the mental health measures that have been collected in longitudinal cohorts. And that's being really enhanced through this as a resource at the moment to make discovery of mental health data more relevant, and work going on with many partners. We've heard about the work with UK Chris and Richard today, but also with the longitudinal linkage collaboration based in Bristol, which is actually bringing cohorts together and conducting linkage to NHS data so that you can work across survey data and other types collected through consented, collected through that with sort of the health records of those individuals. So that's just a little bit on our hubs, and I just want to finish by just telling you about an event that we have on the 28th of June, and it's here in Birmingham, up in Birmingham, or down in Birmingham, depending where you are in the country, but we really hope you may be interested in joining us. So the hubs and the gateway, the alliance, and other activities that HDR UK has delivered over the last 3 years were funded through an industrial strategy challenge fund grant called the Digital Innovation Programme. And we are bringing together all the different components of that for a day-long event to look at how the successes that we've achieved across that and how we can look to the future as we look to develop the next phase of this linked to our QQ. So I'll stop there and say thank you very much.
Thank you, James, and thank you to everyone for joining us today, especially to our speakers. It's been fabulously interesting. I'd like to end very quickly in our last minute, looking beyond sort of health data research and really encourage everyone to engage with Mental Health Awareness Week. The Mental Health Foundation raising awareness of the impact of loneliness on our mental health and the practical steps we can take to address it. And it's an estimated 1 in 4 adults say that they are lonely, some or all of the time. And there's now substantial evidence that shows that loneliness actually has a significant impact, not only on our mental health, but also on our physical health. So you can find out how to get involved and access resources on the Mental Health Foundation website, and I'll just pop the link in the chat for you. And with that, thank you everyone, and see you in September.